everyone. Congressman GT Thompson, Pennsylvania 5th Congressional District, and I want to thank everybody for coming out for this, for this congressional briefing on the state of mental health of the U.S. military. And I'm here as obviously with my colleagues, which I so appreciate the opportunity to work with on a lot of issues, but this one's near and dear to my heart. More than anything else, I'm actually here this morning as an Army dad. And I'm one of those parents that got one of those calls before BC, before Congress, probably back in 2007. Our son was deployed to the 3rd Infantry Division. And it's one of those calls you don't want to get. It wasn't the worst of the calls, obviously, because they were calling to say my son was wounded, but he was alive. But from there, when we did make connection with Logan, our son, who's, I'm proud to say, is now a staff sergeant in Station San Antonio. He was apparent he lost one of his best friends in that ID, and to see what he experienced with that loss, and the call was really hard for Penny and I. First of all, when your son's injured, but more than that, the fact that it was a delayed call because somebody had died, and they had to contact this first sergeant's wife and family. And so, and then I got another phone call probably after I was elected. What the initial on that would be after election, but that was in my first year. And it was a phone call that he called me to talk about all of his friends he had served with when the 3rd ID had been in Iraq at that later deployment. All of his friends had committed suicide, either on post or back in their home communities if they had been discharged following that deployment. And so, and that was my entry into working with these issues, and we've got a great panelist here. This is such an important issue. Make sure that we sleep well at night because of the men and women that serve this country, and they serve us, and we have an obligation, and I know my 2 colleagues and I share a commitment and a passion to serve them, to provide, to make the right decisions, to provide the right resources to serve those who serve, to keep them healthy, keep them well in their training, in their deployment, and quite frankly, when they're done with their service to this country going forward. And so it's a privilege and an honor to be here. Before I introduce one of my colleagues to take the podium, I have the privilege and honor of just giving a little bit of a brief bio on our panelists here today. We've got a wonderful panelist to speak on this incredibly important issue today. We have Dr. Vivian Cisneros Wuerzel. Dr. Wuerzel was born in Los Angeles, California, is a widow of Lieutenant Colonel Richard Wuerzel, Jr., U.S. Marine Corps, who served in Operation Iraq Freedom 1 and 2. He died on active duty at Camp Lejeune in 2005, 1 week after his return from Iraq. At the time of his death, the children were 12 and 14 years old. And as a Marine Corps family, they lived in San Diego, California, Quantico, Virginia, Okinawa, Japan, Camp Pendleton, California, Las Vegas, Nevada, Monterey, California, Vina del Mar in Chile, and Vista, California, and Emerald Island, North Carolina. In 2005, shortly after her husband's death, she discovered she was not eligible for new enhanced survivor benefits and was instrumental in changing the SGLI and the death gratuity so that now all active duty widows are eligible for enhanced benefits, and she's testified before Congress several times regarding inequities in survivor benefits, and her mission is to help correct inequities in survivor benefits and to optimize services provided to survivors. We are also honored to be joined by Dr. Well, go in order here. Dr. Wayne Jonas. Dr. Jonas, he is the President and Chief Executive Officer of the Samueli, hope I pronounced that correctly. Samueli. Sorry about that. Institute. He's a widely published scientific investigator, a practicing family physician, professor of family medicine at Georgetown University, and adjunct professor at Uniformed Services University of Health Science. Additionally, Dr. Jones is a retired lieutenant colonel in the Medical Corps of the United States. Our third panelist is Lieutenant Colonel Christopher Ivani. Chris Ivani was born in Madison, Wisconsin, and attended Providence College, where he majored in biology and earned his commission in the United States Army through ROTC in 1997. Kristen attended medical school at the University of Texas, Health Science Center in San Antonio, graduated with his MD in 2001. He's completed his internship and his residency in psychiatry at Walter Reed Army Medical Center in Washington, D.C., where he served as the chief resident in 2004-2005, also completed a fellowship in child and adolescent psychiatry at Tripler Army Medical Center in Honolulu, Hawaii in 2007. Lieutenant Colonel Ivani has served as the chief of Behavioral Health Division at the Army Office of the Surgeon General and as the Army Director of Psychological Health since April of 2013. And our fourth panelist is Dr. Wendy Tenhola. Dr. Wendy Tenhola serves as the National Mental Health Director for the VA Department of Defense Integrated Mental Health of the Department of Veterans Affairs. In this role, she oversees implementation of the VA-DoD Integrated Mental Health Strategy and the VA's Problem-Solving Training Institute. Dr. Tenhola's professional efforts since joining the VA in 2000 have focused largely on the development, implementation, and evaluation of psychosocial interventions, cognitive functioning in schizophrenia, vocational rehabilitation, and reducing the stigma associated with seeking mental health treatment. Dr. Tenhola leads the VA's efforts to coordinate with the Department of Defense on mental health issues and increase the awareness of mental health resources through its national award-winning Make the Connection outreach campaign. And now it's my privilege and honor to turn the podium over to a gentleman from Ohio, a good friend and colleague, Congressman Tim Ryan.
Thank you so much. We've got a great panel, so I'm going to be very brief and let our other colleague, Napolitano, say a word or two. But just to say thank you to the panel for coming. I think those of us who work on these issues, and I think the country as a whole, are very concerned about what's happening to our men and women in the military, and then also what's happening to them after they are discharged and become veterans and start to access the VA system. And we've been pushing very hard from this caucus and in other ways to promote the kind of approaches that we're going to hear about today, the integrative health approaches that are, I think, having a great effect, and how we can work with our men and women in the military to build the resiliency that they need to help them better deal with the stressful situations that they're going to find themselves in. So we've got a wonderful panel here. I'm so thankful to always work with you and to have you here to spread the word. And thank all of you for being here to learn a little bit more and get the word out to you as a member of Congress. So thank you so much. And with that, my partner in a lot of the mental health work that we're doing, Grace Napolitano.
Thank you so very much, Tim, and my colleagues. Thank you for all the work you're doing. And thank you for taking on Mental Health Month, this very important issue. And Ronnie Romero, who's my mental health specialist, unfortunately won't be with us too much longer, so feel kindly towards us. We're going to be continuing work that we've been doing for many years. As you know, we've been always focused for at least over a decade over the issue of mental health, whether it's children, veterans, seniors, every aspect of what we deal with. Because at the end, people go home from service and they affect the communities that they live in. And we need to be able to ensure that we continue reducing the stigma so that we can continue the work that needs to be done at every level. This 22 veterans dying a day is intolerable. We need to reduce it to zero. And we need to make sure that we all work towards that. And you're going out and talking to other folks about what is trying to be done here in Congress and supporting the bills that are being proposed to be able to help the military, help the mental health service providers and their families be able to ensure that they have a productive life when they go home. We need to do a better job in transitioning, signing up for the military, including imposing upon the military to include them in the VA immediately instead of having to sign up for it. But to be more forthcoming on working with us at the local level, at the state level, and federal level, because it's this partnership that's going to be, would be more productive to everybody. We have a military legislation that 4305 that both my colleagues and I'm co-sponsor on the assessment of all incoming military recruits. We need to ensure that everybody understands that this is something that is not, it's nothing to be ashamed of, that we need to ask for help and reach out. So I thank the panel for being here. I'm going to have to excuse myself to be on the Senate side, but I really thank you and look forward to working with you in the future, especially when it deals with services to the families. And of course, the PTS and TBI are very, very much in the forefront of the work that we do. So thank you for coming, and thank you for being so open and coming and talking to us about this. Thank you, and I'll turn it back over to, I believe, you're the first one, I believe. Yes, Wendy. Thank you so much.
Thank you. Thank you. And thank you for the opportunity to be here this morning. I am Wendy Temple. I'm with the Department of Veterans Affairs, Veterans Health Administration. And at VA, we have both the opportunity and the responsibility to anticipate and to respond to the mental health needs of returning veterans as they reintegrate into their communities, as they go on to try to live the most fulfilling lives they're able to. It's our responsibility to ensure that if they need mental health care, that we are providing them with the highest quality care possible. So what I thought I would do this morning first is introduce a couple of colleagues from VA that I'm accompanied by. Dr. Dean Cron is the Deputy Director of VA Mental Health Operations, and Dr. Al Ozanian, these two gentlemen in the front row here, is the Assistant Deputy Director of VA Mental Health Operations. And what I thought I would do with the time that I have to speak with you this morning is try to answer three questions. Who is the veteran population that we're seeing in VA? What are we doing in VA to try to help service members as they transition from DOD, from active duty to VA, to veteran status? And third, what happens in terms of mental health care once they come to VA? If someone does need mental health care and they choose to seek that care at VA, what is it that they're going to receive there? I in this time, can't give you a full in-depth overview, but I think can hit some highlights, and then I think we have some time to answer questions if it raises questions, so happy to do that. So the first question, who is the veteran population that we're seeing in VA? Since 2002, approximately 1.8 million veterans who have served in Iraq and Afghanistan have become eligible for VA health care. So that's about almost 1.8 million service members who have left service and are eligible for VA health care. A little bit over 1 million of those have actually sought health care at VA. So that's about 58% of those individuals have actually obtained health care within VA. And those veterans from the recent conflicts in Iraq and Afghanistan are presenting to VA with a wide range of difficulties, the most common of which is musculoskeletal, so outside of my mental health realm, muscle and joint pain. But second on that list is mental health concerns. So mental health is the second most common type of diagnosis that those veterans who are presenting from the current conflicts are coming to VA and seeking care for. Among those mental health conditions, post-traumatic stress disorder is the most common diagnosis. Depression and other mood disorders, as well as anxiety disorders, are also quite common. And those are then followed by substance use disorders. So those are the most common sorts of mental health concerns that we're seeing in VA amongst returning veterans. And then if we step back a little bit further and consider all veterans who have used VA healthcare, not just those returning from the current conflicts, and just so you know, those returning from the current conflicts comprise about 10% of who VA is seeing at this point. So still the bulk of the patients that we're seeing in VA healthcare are veterans from previous service eras prior to the current conflict. So stepping back and looking at the whole VA patient population, in 2013, over 5.5 million veterans used VA healthcare. And I'll stop with the boring numbers in a second. I just thought I would sort of set the stage of who are we seeing. Sorry, I realized as I'm spouting these numbers. So of those 5.5 million veterans who were seen for healthcare in 2013 in VA, about 1 in 3 have a possible mental illness that is somewhere in their chart, a mental health diagnosis appears, and about 1 in 4 have a confirmed mental illness. That means that they are seen for either an inpatient or residential care visit, or at least 2 outpatient visits with a mental health diagnosis in their chart for those visits. So that's about 1.4 million veterans in 2013 that we're seeing in VA for mental health care. So we have a lot of work to do in this area, and are trying hard to do it. And one of the areas that we're working on is trying to facilitate when someone is leaving active duty, when they're leaving service in the Army, Navy, Air Force, Marines, Coast Guard, that we are helping them transition to VA care as smoothly as possible. And I'll just highlight a couple of efforts in that area. One is actually a DoD program that we work closely with. It's called the In Transition Program. It's a coaching and support program designed to serve service members who are undergoing any sort of transition in their career, whether they are leaving the service, whether they're transferring to another healthcare system, whether they're going to a new duty station within DoD. It's focused on helping those who are already identified as needing behavioral health or mental health care, and helping support them in those transitions. So they're already in care and making a transition. How can we help support them in that transition and ensure that they get the care they need on the other side of it? And so the In Transition program, from a VA perspective, we've worked closely with that team to develop joint trainings to make sure that VA providers are aware of this resource and are able to make referrals to it and readily receive referrals from the program and get patients into care. The program has had of service members who have responded to satisfaction surveys on In Transition, about 95% have said that they were pleased with their services that they received and that they would recommend it to others. And I think even more striking to me is that 93% said that they were more likely to engage in treatment on the other side of their transition as a result of their experience in the In Transition program. So that's a program that we work closely with in VA. As I said, it's focused on those who are already identified as needing mental health care, already in mental health care. They're expanding their efforts a little bit to, more than a little bit, they're expanding their efforts to reach veterans or service members who screen positive, so answer some questions indicating they might have mental health concerns in the post-deployment health reassessment process, but who aren't yet in mental health care. Those service members also can receive a referral to the In Transition program. A couple of other VA programs I'll mention, and you guys tell me what I'm doing. A couple of other VA programs that I'll mention. One is VA Liaisons for Healthcare, and through that program, VA has 41 liaisons who are mostly social workers and nurses stationed at 21 military treatment facilities. So they work side by side with the DoD care providers, providing on-site consultation, educating service members and their families about what resources and treatment options are available to them once they leave the military, and helping facilitate the transfer when someone is leaving a military treatment facility and going into VA care. And to date, those liaisons that are part of that program have facilitated or coordinated upwards of 52,000 transfers from military treatment facilities to VA, either inpatient or outpatient care. A second program within VA that I'll mention is the transition and care management teams that are located at each VA medical center. These are teams of providers that are specially trained in addressing the needs of returning combat veterans, of identifying not just VA resources, but also local community resources to help them and their families readjust to civilian life and get engaged in any care that they may need, whether it's medical care, mental health care, whatever kind of care it is that they might need, and help them recover from whatever injuries they might have, and as I said, readjust to civilian life, both for them and their families. So I will also just mention quickly that VA Another thing that VA is actively engaged in with DoD is outreach to service members who are transitioning to VA. There are a lot of service members who, as they're leaving military service, as they're leaving active duty, they may not be in need of mental health care right that minute, but they might discover later that they're having a problem, or problems might emerge later. Or they might be aware but not necessarily want to seek mental health care in VA at that time. And so for those people, which is a large number of people, if we can make sure still at the time of transition that they're aware of what is available to them, if they do determine there's a need, or if they do decide that the VA is where they want to go to help address any mental health concerns they have, then we have provided a tremendous amount of outreach and assistance as part of the Transition Assistance Program and other sorts of outreach programs as service members, active duty, National Guard, and Reserve are transitioning from active duty status into veteran status. And so that's an important component of what we do, because not everyone, we're not seeing people necessarily at the moment when they're raising their hand and saying, I have a mental health problem and I think I need some help. No matter when we're seeing them, we want them to know about the resources that are available. So I wanted to just mention that. And then, so that's a little bit about what we do related to transition from service into VA. Lastly, I'll just try quickly to answer a little bit of the question of then what happens if someone does come to VA for mental health care? What is it that they will receive? What services are available? For veterans who, if they have mental health needs, choose to seek their care at VA. And I will say that over the time I've been in VA for about 14 years, and over the time that I've been in VA, I think our system has made strong progress with regards to improving mental health care. We have a lot of work to do. We will always have a lot of work to do to make our system better and to make that care better. And we are working to make that happen. But I think we have made a lot of progress. Within the VA system, there are lots of different entry points into care. There are 151 VA medical centers. There are 820 community-based outpatient clinics, and there are 300 vet centers, all of which offer a full range of mental health services. And once someone comes to us for mental health care, that care, we endeavor to make that care veteran-centered, recovery-oriented, so focusing on recovery and leading a fulfilling life, and evidence-based. What is the evidence? What does the research show is effective? Is going to be effective for this person who is sitting there in front of me with a need. VA offers a full continuum of mental health care, from inpatient and residential care to specialized outpatient care to mental health care that can be provided in primary care clinics, and mental health care that can be provided in various other settings. We work closely with the homeless program office. We work closely with veterans who are involved in the justice system because of mental health concerns. We work closely with student veterans on college campuses. And so really the full range from you're in the hospital acutely in need of mental health care to you're out in the community and experiencing some distress, having some challenges, or not quite sure what to do about them. Being able to address sort of that full continuum is what we try to do. VA, as many of you know, has undertaken tremendous amount of effort in the last several years with regards to suicide prevention, and has a veterans crisis line that's available 24/7 with experts trained in dealing with crises and in suicide prevention. That line is open. It's a toll-free phone line. It's available through text and an online chat service as well. And it's available to veterans. It's available to active duty service members. It's available to a family member or other person in the community who cares about an active duty service member or a veteran. And through the crisis line is another way that people can get linked into the care that they might need. Another thing that I'll mention, and then I'll stop, is that VA clinicians also proactively screen for post-traumatic stress disorder, depression, substance use disorders, as well as military sexual trauma. So even if someone's coming to VA for health care, they will get screened for those things so that we can help proactively identify if they are having problems, even if they're not spontaneously reporting them or coming to VA just for that reason. We think that will help people get into treatment earlier and more proactively before things get worse and harder to deal with for them. So, and we also have made efforts around the country to offer longer clinic hours and offer things like telemedicine to make it easier for veterans and their families to take advantage of the services that we do have available, realizing that people can't necessarily come to the clinic, between 9 and 5. How can we make if we, have done all this work to improve the services that are available, how can we make sure that that it's convenient for veterans to receive those and that they're able to receive those services in a way that's most helpful to them. So one last thing I will mention is a few resources that are available. So I've been talking a little bit about services that are available once someone comes into VA. There are also a number of things we've been working on in recent years, a lot of which we've been working on with DoD, recognizing, as I said at the very beginning, one of the numbers I threw out there was that 58% of OEF, OIF, O&D veterans who are eligible for VA care have come to VA for care. That means 42% of those who are eligible for care are not walking in the door of a VA. So we've done a lot of effort over the last several years to make resources available to veterans regardless of whether they're coming to VA for care, if they need them, and especially information so that they know if they need care and know how to get that care if they do need it. So for example, we've developed a public outreach campaign called Make the Connection, which is the focus of which is trying to reduce the stigma associated with seeking mental health care, to educate veterans and their families and the general public, frankly, about mental health concerns, and to encourage those who might need mental health care to seek that care. And the focus of that is doing that through veterans and their family members telling their own stories of having sought care and how that care was effective for them. So that's the Make the Connection campaign. I mentioned the Veterans Crisis Line being available even to veterans and service members who are not seeking VA care or in VA care. We've developed a variety of mobile phone apps that are available to the general public, all for free. Things like PTSD Coach provides education and mechanism for tracking PTSD symptoms, either as part of treatment or just on someone's own. There are apps for insomnia. There are apps for helping someone to stop smoking, etc. And there are also some web-based self-help courses that are available 24/7. Anybody who is interested and wants to work on a problem but doesn't necessarily think they need to or doesn't necessarily want to go into VA. One of those is focused on parenting. And it's focused for veterans and service members on parenting and specific issues related to parenting that come up related to military service. And the other one is focused on an evidence-based intervention for problem-solving training. And so whatever challenges somebody might be facing, they can go online and learn very specific skills that will proactively help them manage and deal with those problems themselves. And again, these are just some resources that are available regardless of whether somebody's in VA care, whether they want anything to do with the VA, but that are specifically veteran focused and focused on the mental health needs that we know exist among veterans. So with that, I will stop babbling and pass the mic over to Lieutenant Colonel Ivany. And then I think we'll all do our comments and then do questions at the end. So happy to take questions at the end.
Thank you, Wendy. Thanks everybody for the chance to be here today. I'm here as a officer in Army medicine, and I think it's appropriate that we're here to talk about the forward movement within this area. Army medicine has been very engaged in trying to transform from a healthcare system, a traditional healthcare system, to a system for health. What does that mean? It means that trying to transition this from the mindset of a hospital-based, disease-focused treatment entity to one that extends beyond the walls of the hospital to proactively influence those within the Army towards health to hopefully keep the rates of incidence of common conditions, health conditions, mental health conditions lower so that we can bend the cost of healthcare and more importantly, help keep people healthier. So Army Mental Health has been on the forefront of that larger Army medicine effort now for several years. Really to best understand where we're at now, it's probably helpful to look back a few years. And if you would have looked at Army behavioral health about 5 years ago, in the midst of the two ongoing conflicts, Army medicine leaders realized at the time that the system was not, the Army behavioral health system was not adequately staffed and was not properly designed to handle the volume of and the type of mental health conditions that soldiers and their family members were dealing with. And so over the course of the next several years, probably 2 to 3 years, it was a emphasis, mostly at the local hospital level on all of our installations, to innovate and to develop new programs and new ways with new resources that were allocated to better take care of the mental health care for soldiers and their family members. And we had quite a few successes over the total Army force. But the challenge was that it was very hard to tell which programs were actually the most effective ones. There were actually 211 different ways in which mental health care was being delivered, depending on which installation you were going to. So the challenge for Army medicine over the course of the last 2 to 3 years has been to find the best practices among the entire force, replicate those practices at all other Army locations, to make sure that beneficiaries at Fort Drum, New York get the same best practice treatment as they do at Fort Carson, Colorado, or Fort Polk, Louisiana. And that has been our focus. We have narrowed the list of programs down to 10 key clinical programs and 1 key medical IT system that helps to support all those things together. So we've identified what those best practices are based on standardized outcomes and clinical metrics, and now implementing those across the force. We're probably about 2/3 of the way through that process, and I want to highlight a couple of those programs that we have identified as best practices and are moving forward with across the whole Army. One is the placement of behavioral health providers within the primary care clinics. So this is part of the patient-centered medical home initiative. It's actually a national level initiative that has come through DoD and down to the Army. So the importance of having a behavioral health provider actually physically located within a primary care clinic is severalfold. One, obviously, is that it improves access to care for those folks. They don't necessarily have to, if they mention to their primary care doc they have a mental health concern, they don't have to go through the referral process of putting a note in the computer and then getting called back later. They can simply go down the hall to make their first contact with a mental health provider, which is in some clinics up to 30 or 40% nationally. If you wait for a referral system to work, you're going to lose 30 to 40% of the people that you know need mental health care. So that's one aspect. Secondly, is the focus of those folks in the primary care clinic, these health psychology trained mental health providers, is not just to treat mental illness, but to help primary care providers and the rest of the patient-centered medical home team to focus on wellness. So to focus on exercise, nutrition, sleep, smoking cessation, other things that we know precede mental illness or can be complicating factors towards mental illness. The role of that forward-positioned behavioral health provider in the primary care clinic is to try to help influence on the very front end. So that's one thing. Secondly, within the first level of specialty mental health care, so meaning when soldiers have a mental health condition that has been identified that's going to need some type of treatment. It used to be that those soldiers used to have to be referred up to the main hospital typically, or some large clinic on our large posts. But a program that was started about 4 years ago now, and is now being replicated across the force, is one which brings mental health professionals, multidisciplinary teams of psychiatrists, psychologists, social workers, techs, nurses, out of the hospital and puts them in small clinics which are actually located in the unit's footprint. So you're in a particular brigade located on Fort Hood, Texas, let's say, you don't have to go figure out how to get all the way up to the hospital across Fort Hood, which is a pretty big place. And if you're a private, you may not have a car. And you may have to figure out a way to get across there. Now, at 50 different locations where we have constructed these new clinics and have these teams out forward in the brigade locations, you simply have to walk out of your barracks and maybe past the motor pool or past where you eat lunch every day into the mental health clinic, which is located right in your area. One of the other advantages of having mental health care out in the unit footprint is that we're able to develop much more effective relationships between our behavioral health providers and the unit commanders and the unit leaders. So those that know the Army know how important the influence of leaders are at the company level, at the small unit level. In other words, your sergeant, if you are a private or a specialist, let's say, your sergeant or your sergeant major has a huge influence on your life. They determine what time you wake up in the morning, what time you get to eat, what time you go to bed, when you're going to the field, when you're coming out of the field, and just about everything in between. So we know that as effective as many of our treatments for mental health conditions are, both the traditional and other newer approaches are, what is actually that our data has shown very clearly, what's much more important actually, is how you're treated in your unit and the conditions that your unit leaders are setting for you to either to get better if you have a condition, or even prior to having a diagnosis of a mental health condition. There's been good data that's shown that if you expose the same type of infantry units to the same levels of combat, and you look at the incidence of post-traumatic stress disorder that comes out of those folks a year or two later, the most important variable is the quality of the small unit leadership and how the unit leaders treat those soldiers. In other words, do they support them when they have problems? Right? Do they make them do extra tasks? Do they help them get to their appointments to the clinic? All those kinds of things that we sort of take for granted are magnified within the Army because of the structure that is in place within the military. So the importance of bringing behavioral health providers and bringing them out to the unit footprint is not just to make access easier for soldiers, but it's also to build relationships so that mental health providers can help advise commanders and first sergeants and company commanders, young guys, 25, 28 years old, who are leading groups of soldiers and trying to make decisions about how to best lead their unit, balance their mission with taking care of their people. And so when you have relationships, ongoing working relationships, our mental health folks can be much more effective in helping those commanders and those young sergeants to make good decisions that take care of their soldiers and help them get better quicker, or hopefully even prevent them from getting sick in the first place. Third, I want to highlight the child and family mental health section of how we move forward. We over the course of the last 10 years have focused almost exclusively within the direct care system in most places on the needs of soldiers due to the high volume of mental health that was coming out of our soldiers. We've used the TRICARE network more and more to take care of the child and family aspect. Just give you an example, I'm a child-trained psychiatrist. I spent 2 years in a fellowship to train specifically after my residency in child psychiatry. Since I graduated from fellowship over almost 10 years ago, I've seen about 5 children in total. All the rest of my clinical practice is all focused on soldiers. And similar things have happened across the rest of the force. So about 3-4 years ago, folks realized that we're working within the context of a national shortage for child-trained social workers, psychologists, and all mental health providers. And we needed to do more within the direct Army healthcare system to take care of those issues. So we've developed several ways to do that. One is by through school behavioral health care. So this is prominent in a couple areas of the country, Maryland and other places, where we have positioned mental health care providers actually within the schools on Army installations. So we have small clinics so that kids who are identified by their parents or through the school leadership team can access mental health care right there physically within the school. And over the course of the next 2 years, we hope to have at least one mental health care provider within every school on an Army installation. Secondly, we've also greatly expanded the telebehavioral health capability for our primary care providers to be able to much more easily access mental health care for tough-to-handle child psychiatric issues for which they may not be trained as well and need consultation rapidly. And all that has led to a great expansion in the use of mental health care. We had about, in fiscal year 2008, there was less than 1 million total contacts between Army beneficiaries and Army mental health care. Last year, there was over 2.1 million contacts, so more than double the number of visits of all types for all beneficiaries that has occurred. And we think that has greatly helped in getting mental health care to folks early in the course of their condition so that we can prevent bad outcomes from happening, bad things that happen down the road. One of the things we watch very closely there is how frequently those within the Army need inpatient mental health care. So our goal obviously is to identify conditions and treat them in the outpatient setting as much as is possible, and most conditions can be treated in the outpatient setting. Our goal is never to drive inpatient care to zero. We always will have a goal for that. But we know that the more effective job we do in the outpatient side, the less we need to hospitalize our soldiers and family members. Last year, in 2013, was the first year since 2004 or 5 that we've seen a downturn in the requirement for inpatient hospitalization, despite a continued increase in the outpatient utilization. So we feel like these programs that I mentioned to you and several others that are part of the Army Behavioral Health Core 10 clinical programs are making a difference. We still have a long way to go to get where we want to be. We think that we've certainly come a long way in the past couple of years. Thank you.
That's great. My name's Wayne Jonas. I was Army doctor for 24 years. I now run the Sandy Welly Institute. It's an independent nonprofit research foundation. Does a lot of work with the VA and the DoD, especially on mental health. I'll give a little bit different perspective here. The programs that Dr. Ivey and others have mentioned are fabulous, and they're going in the right direction. There's no question about them. When I was trained as a physician, I was trained to sit at the top of the heap, to know everything, to write all the orders, and everybody else just followed. Okay? The medical home says, no, we need to do something different. We need to set up teams in which the deliverers, like the mental health professionals that were mentioned here, actually out in the field or in the community, helping individuals where they're at. In other words, what the patient needs, the whole idea of being patient-centered. It's a great idea. It's very hard to implement for folks like me, or for a system that is actually structured not to do that. It's structured to actually deliver what they think is the needs of the patients, or the communities, instead of listening to them and then trying to adapt that. Lieutenant Colonel mentioned the mental health coaches that are now helping with wellness. And that's fantastic to get them trained in the ability to develop wellness, but that's a different specialty actually than mental health, and most people know that. It's a health coach. The behavioral change that's needed as part of that is not part of mental health training. It was not part of my training. I was trained to see if the quickest way I could get people through so my productivity would be up. And that meant 15 to 20 minutes or 5 minutes in sick call, and usually end with a script, a drug. And that's still the way the system is set up. The system still, the vast majority of things, deliver those types of things. So the statistics you've heard, you know about, there are a huge number of those with post-traumatic stress disorder, with depression and anxiety that we mentioned, that have come back in the last 10 years of the war, traumatic brain injury, which then is results in a conglomeration of things that come together. They're called comorbidities in technical language. They have to do with pain, they have to do with cognitive difficulties, they have to do with emotional problems, and they have to do with the problems of encountering the medical system and getting drugs, so opioid dependency. So the study will come out next month that shows in a unit that came back from Afghanistan, 45% of those actually ended up with chronic pain problems. 15% of those on opioids. 6% with no pain on opioids in those areas. We have a huge drug industry that keeps writing scripts and keeps telling us to do that. It's the easiest, simple thing. The programs that were described both in the VA and in the Army and the military are moving, trying to turn that battleship, trying to turn the tide to provide more self-care drugless approaches to enhance these areas. But I can tell you that it's not fast enough. It is not fast enough. About 8 years ago, we did a study showing acupuncture had an effect size for treating PTSD. This was done at Walter Reed with our investigators and those in the Deployment Health Center. The effect size of acupuncture for alleviating PTSD was just as large as any other treatment that existed, but it didn't use drugs. It was very easy to deliver within a month, and it lasted even after it was stopped. There hasn't been a single additional study funded by the DoD on acupuncture and PTSD since then. It's trickling in. Okay, we need to markedly accelerate these areas. We did another study at Camp Lejeune with Marines showing a simple mind-body technique, healing touch and guided imagery, could train individuals to help manage their own emotional volatility, reducing aggressiveness, improving cognitive function, reducing depression, and needing less medications in those areas. That study published in Military Medicine, there's not been another single follow-up of that in those areas. Military says you can get these kinds of services, self-care services, drugless approaches in these areas, and you can in some places, but it's completely unsystematic. It's not centralized, it's not evaluated, and it is not emphasized in these areas. And so you can go down to the National Center of Intrepid near Walter Reed, Bethesda, and if you go in there, you can get them. But as soon as you go back out to the field, it depends on if there's a champion, if there's somebody that's been trained, maybe they've been trained correctly, or maybe they haven't, and frequently they're not available. So they're there, but they're not available to the general population and to the folks that need them in those areas. So there really needs to be an increased emphasis in those areas. You know, the basic message is that war is hard. We all know that, right? It's difficult. People get hurt. A lot of people get hurt. And it isn't just those who go to war. There's 8 to 10 individuals, family members, that end up being the caregivers or end up being involved in helping for the rest of their lives, managing and working with these individuals when they come back. That affects a huge population. Recently, the costs of doing business as usual, simply providing more services, more medical services in these areas, are going to be the biggest national threat, according to the Kennedy School of Government. Over the lifetime of those service members that have come back and transferred to the VA, simply providing more medical services and benefits are going to cost us nearly $5 trillion. I mean, we all are going to be paying for that. Our children are going to be paying for that. We need to bend the cost curve. We need to emphasize things that truly retrain individuals to come back into society. We spend a lot of time training them for war. We empower them to be good service members and soldiers, and they do a fantastic job. When they come back, we provide them with medical services. We disempower them. What happens when you walk into a hospital? You've made decisions about your own health care up until that point, but then you're put in a row, right, and somebody's telling you what to do. You get disempowered. Our system is set up to do that. We need to reintegrate, retrain them, and spend at least as much time in the self-care kinds of practices and reintegration of those efforts. So the efforts that were just discussed are all moving in that direction and attempting to do that. We have a system that isn't set up to do that. We have a system, and so we need to rethink how to do that so that those services can become widely available in those areas. We recently mapped all of the wellness, what the former chairman of the Joint Chiefs of Staff called the total force fitness practices down at Camp Lejeune and the Marine base down there. Found there were somewhere between, actually didn't know all the programs that were down there, there were somewhere between 80 and 120 programs established funded programs, but less than 2% had any evaluation whatsoever. So I'd love to hear the 10 practices that the Army's now evaluated and said these are by far the best practices in those areas, because very few are actually getting evaluated. And as the DoD shrinks and as the budgets get cut, we're not going to know actually what works and what doesn't work in those areas. So there needs to be some kind of centralized emphasis on self-care practices, on drugless approaches in these areas, that where the research needed to actually figure out how to implement this is adequately funded, and not simply more service as usual. And we need to evaluate them to know what works and what doesn't work, so that we're not simply cutting and willy-nilly in those areas. So I'll end there and turn it over to the next panel.
Good morning. Can everyone hear me? Good. Because in real life, I'm an audiologist. I'm Dr. Vivian Morsel. I'm the surviving spouse of Lieutenant Colonel Rich Morsel. As you know, he died suddenly, but I had 2 children. When I received the message that I was requested to participate today, my case alone could have sufficed, but that's not why I'm here. I decided to pulse the community of Woodsters. Woodsters is what we call ourselves. We're widow sisters. We're a new sorority of military surviving spouses that bond very well. So I pulsed the community of Woodsters and said, you tell me what's the good, the bad, the ugly, but I really want to focus on what works well. We all know the baby's ugly. There's no reason to spend thousands of dollars and say it didn't work. Let's look at what does work and perhaps either make it better or expand on it or share the news. So I'm going to talk a little bit about us. And the consensus was that there is no one-stop shop to have our support for grief. Not one organization, but it's really made up of multifaceted support of many different organizations, whether it's the NGOs, the military, the VA. Everyone had great support and things to say about all the organizations, so we really need a multifaceted support. There are many different reasons why one wouldn't work for the other. There are independent variables that influence our grieving process. The types of death, long-term, knowing that the train's going to wreck, if you know your husband's going to die with a long illness. But our deaths are not like that. Our deaths are sudden, or they're violent. And that has an adverse effect on how we're going to grieve, or whether or not the grieving process is going to be prolonged. Besides the type of death, you have to think about whether or not we had children or no children, which is actually, for a lot of these surviving spouses, that is worse yet, because they miss the opportunity to have a child, and that can never change. Their life experience under their belts is going to vary, so some will be more resilient than others, depending on age, of course. And it's difficult to predict how we handle our grief, as there is no timeline in grief. Some may put it on the back burner until they get done with certain things in their lives, and then the grief will come up. So just because someone's died 3 years ago and all of a sudden they decided to face the grief, that was when they decided to work with it. But due to our typical deaths that are sudden and violent, our grief is unique, complicated, and complex. Bereavement counseling must be made available and appropriate. So I'm going to go in to describe who is this widow? Well, I did some research, and there's not much out there, but there is an article by Caucus et al. About the statistics of the past 10 years. Since 9/11, there's been about 16,000 deaths. Of the 16,000 deaths, 95% were male. Of those male, 50% were married. They had at least one child. So we can make an educated guess that that widow is going to be young and with a small child. So with that said, that young widow probably doesn't have, again, a lot of life experience under the belt or tools to work with. Next thing I'm going to talk about is how this debt has an adverse effect on our optimal well-being. Optimal well-being is quite important. As you know that with the mental health, if our optimal well-being isn't intact, there will be repercussions. What happens is that as soon as there is a death, there is an identity change. We are no longer the military spouse. We lost that identity. We are now the widow. And losing a husband is one facet, but losing also the military family, it's another loss. The family dynamics, we have a widow whose husband was married before, so there was a stepchild involved. Well, once that happened, that stepchild is no longer part of her life. She lost her husband and she lost her stepchild. That's two losses. It's another dynamic to grieving. Decisions. Decisions are having to be made. Quick decisions are having to be made. They're going to affect the rest of their lives. Deciding whether or not they should have an option for benefits, spouse option, or is it going to be a child option? And for you, those who don't know our benefit issues, it's like, where's the acorn now? You got a VA payment, you got a DO payment, DOD payment. Do you do both? You can't. If you do, you offset it. It's so confusing, but within the first week or two, those widows are having to decide. Unfortunately, they regret the decision that was made for them, or they made under the fog of grief. One of the recommendations I'd like to see is DOD consider that the first year, that major decision that haunts them today, they have availability to change within that first year, a grace period to say, I would like to have the SBP, unfortunately, offset by my DIC. These are terms I know. But it's the dependency indemnity compensation and the survivor benefit plan. But they would like to change it, but it's too late. But those decisions that were made early on adversely affect how they are today with their anxiety, because they worry. They can see the financial nightmare looming on the horizon. However, my other note on that, if that offset was removed, it would never have the problem. So that's another story. We have many different behavioral changes. We have physical changes. We have cognitive changes. We have spiritual changes. We are, if you put it all together, it's not a pretty look. We really go through a lot of different changes, and the best way to describe it, if I was to explain to anyone what we have to go through, we end up aging like dogs. For every year you've been a widow, you've aged 7. It is not a simple life. It is very complicated. You know, even our sleep. Many widows, I don't know if many of us have good night's sleeps. And I tell many people that after a death, widows sleep like babies. Every 3 hours we wake up and cry. And if that doesn't take a toll to your physical well-being, it will. So those are, and I know you all talked about it easier, sleep is very important to our health. And if we're not getting the right sleep, then it will have an adverse effect. Every widow is unique to the situation, financial challenges and grieving process, as well as whether or not the husband left money. And you think, well, this is all about money. Well, unfortunately, there are some hiccups during their death, and it does impede the ability to grieve and get the care. For some, the surviving spouse was not left the SGLI insurance, or there was a divorce. So the widow now has a complicated grief. She despises the man who died or was killed, but grieves and mourns for the man she fell in love with. So there's not just one case of one widow. There's many different types of issues that can come up. What I'd like to talk about now is what challenges did we face? And I really try not to perseverate on all the bad. It's not the bad, it's just the challenges. The challenges that we had were getting care in military treatment facilities. And maybe it was because, depending on where you live, maybe it was too far, or the hospital itself wasn't prepared to support with children. Now, mind you, the input has changed, the input's today, but the times of the deaths have changed. So there's been a lot of growth. And so if it wasn't available then, I know it's been improved, but that was a challenge for a lot. The stigma of the ICD-9 code of depression. Nobody wants the ICD-9 code of depression, and that's how we were billed for grief. If you went for a medical appointment, you tell them, I lost my husband 3 years ago, but I want to talk about it. The only way TRICARE would pay for that was to go ahead and put ICD-9 on depression. That's going to change with the new ICD-10 code, so that works out well. Proximate summits. Some widows drove from Fredericksburg to Walter Reed. Why? Because the care was good, but the challenge was the drive. It took a day off work and a day out of school. Difficult getting referrals because not understanding how TRICARE works. Was it a direct referral? Was it not a direct referral in the civilian sector? The Vietnam widow, she missed the opportunity of having counseling available, but the Vet Center has provided them well. I did get input from the Vietnam widows. What worked really well, and this is really important, is the professional mental health support, TAPS Good Grief seminars, Good Week Camp for children, the Focus program, Families Overcoming Under Stress, the VA, Vet Center, military treatment facilities at the Vet Center. These are programs where they can get professional help. For peer support. Peer support is phenomenal. As part of the healthy process, widows share lessons and provide support when needed with their fellow Widsters as part of their peer support, helping others less fortunate and looking in the rearview mirror. These widows will look back and recall, this is what was hard for me and I can help someone else. Our social media is phenomenal, and this is where everybody gets to vent in their private and closed. Many organizations provided support, but sensitive understanding is no one should go through grief alone, regardless of location and circumstance of death. They provided emotional, healthy, physical activities, bringing widows together along with their children, building healthy relationships, allowing the widow to be a widow, allowing them to grieve. And this is really important for the surviving spouses. There's a stigma. A lot of organizations did not include them in their programs because they were the survivors of suicide. And TAPS is one of the first organizations that welcomed them in with open arms. And it made a difference for one of the families that submitted their input. There are such groups as Gold Star Wives of America, TAPS, Crisis Hotline, seminars, Good Week Camp, especially for suicide survivors, TAPS, Army Post. The Survivor Outreach Services and the Army Post is a wonderful place to go. They provide services for all branches of the services. They may not give the service there, but they can tell you where to go to get it. And that's important, so as long as there's a place where they can to contact with, and I hope the Army will keep up the SOS programs. Having simple access to counseling without referral sources, TAPS, Military One Source, a quick connection while in the need of crisis, which I must say I have used and it works well. The takeaway is the recent widow from this current conflict is young, without a lot of life under her belt to help her. Bereavement counseling and connecting with other peer mentoring groups should be available with easy access and is imperative early on when the death is fresh. We need to assure our coding for treatment is appropriate and so it does not interfere with our future. To bring your attention to this also, that thousands of Vietnam widows are not seeking support, but hopefully the VA will put out a message saying that the Vet Center is also open for them if they have the benefit. We are unique. Our deaths are sudden, sometimes violent. Our reactions vary, yet wide range. But we should continue to strive to improve our benefits, and with your support with the community, we can provide the support for the surviving spouses and their families. I thank you for the opportunity to speak today, and I will tell you right off the bat, I didn't think I could talk for 10 minutes, but I can talk forever, so I'm going to take my whole thing off and stop. And I'll take any questions you have to offer. Thank you.
questions now, if there's any questions. Actually, I have a question for Wendy. So other than the social outreach, social media outreach and the missing, making connection kind of, what is the VA doing to make people more open to going to the VA for help? And are there suggestions on what we can do to kind of help that as well?
So the question was about what is VA doing to make people more open to going to the VA for help? One thing you mentioned, Make the Connection, is a national outreach campaign to really help people understand. I think if people understand that what they're experiencing is something that is treatable, that treatment is available, that treatment works, other services or support is available, that they're not alone, then they're much more likely to seek out some sort of care. VA has worked hard, as I said, to make our care high quality and make effective treatments available. But I honestly, if someone is struggling, want them to get care or support or treatment wherever it is that they feel most comfortable getting that care. And I think the community at large can do a lot to try to reduce the stigma and support those people who are struggling and may or may not want to seek care, at all, or with the VA. I think there's a lot that the community can do outside of VA to encourage people to get care if they need it, but also support them in the community. Things like jobs and relationships and other things that affect your quality of life also affect your mental health. And so to the extent that the community and our services are supporting the other elements of people's lives, then we're also supporting the mental health.
Any other questions?
Hello, good morning, Andrew Kessler. I represent substance abuse treatment counselors, and including those in the armed forces. And I'm curious if you could address the treatment of substance abuse and any progress in terms of a single diagnosis for substance abuse rather than having it as a subset of mental health for those who present with addiction or substance abuse issues that may not necessarily have a co-occurring mental health disorder.
Sure.
Whoever wants to have
Sure. Well, I'll say off the bat, the Army certainly does not set the national diagnostic practices, right? So we follow the diagnostic practices that are laid out at the national level, and so that's, I think that part is one step beyond what we can control. However, some of the key aspects of ensuring that substance abuse, both screening for substance abuse conditions and then easy treatment or easy access to treatment for substance abuse conditions is very important. One thing that the Army has done recently is instituted screening for substance abuse conditions as a part of the routine mental health and physical screening that occurs at all the touch points when soldiers are screened. So it does not require sort of a subspecialty level assessment. So you can go right from the initial screening right to substance abuse and stop through mental health care, for example. And you mentioned that the dual diagnosis patients. So you don't need to have a mental health condition to receive a referral sort of to substance abuse. There's also been steps made within the military, and maybe in other services as well, to provide confidential access to substance abuse treatment. So Army substance abuse treatment centers are open off hours, don't require any kind of command notification or command referral to use those services. And as long as there's nothing illegal going on or endangering somebody else, then that treatment is not revealed to anybody. And the efforts are made with the clinic hours on Saturdays and after hours to make sure that, especially folks that are more senior ranking, are the ones that are typically most reluctant to access substance abuse treatment. So there has been some additional access to substance abuse treatment through that program. Right, so those are actually on post, but it is eligible off post.
Hi, I'm Heather Parsons of the American Occupational Therapy Association. I was wondering if you all were seeing a link between traumatic brain injuries, even like low-level traumatic brain injuries and mental health issues further down the road, especially as people come back with cognitive changes, small changes leading to depression. And if so, is there extra outreach for people who've had that kind of injury, from the VA? Is that one of your target groups?
And certainly the individuals, veterans who have experienced a traumatic brain injury and are experiencing any symptoms or difficulties as a result of that, we are reaching out to as I mentioned, the proactive screening that we're doing for depression and post-traumatic stress disorder and military sexual trauma and alcohol use. Every patient who comes into the VA also gets screened for whether they've experienced a traumatic brain injury. So we certainly are looking at that and reaching out with our colleagues in the rehabilitation community to make sure that we're identifying and providing the full range of services that are needed by individuals who might have either both a traumatic brain injury and a mental health condition, or some of the symptoms that you mentioned that can be associated with a traumatic brain injury that psychosocial interventions can be helpful for. So we certainly are looking at those things together. Thanks, great question.
Anyone else? Great, well, I want to thank our panelists for coming and for all of you guys for coming to the briefing. And if you have any follow-up questions, you can contact them, or you can contact me in Congressman Ryan's office, and Congresswoman Napolitano's office.